welcome to the deep dive. You asked for it, so here we are. A really focused, high-yield look at colorectal cancer, aimed squarely at your MSRA prep.
Exactly. Think of it as the essential info, distilled down. We want to get you up to speed quickly and make it memorable.
Perfect. So let's dive right in. What exactly is colorectal cancer? How do we define it?
Okay, so basically it's a term covering malignant growths that pop up in either the colon or the rectum.
Right.
These cancers start from abnormal cell growth in the lining of the bowel. And, most of them are actually adenocarcinomas.
Adenocarcinomas.
Yeah, and they typically develop from polyps, usually over quite a long time. It's not often a sudden thing.
I see. A gradual process then. So what actually kicks this off? What's the etiology?
Well, the exact trigger isn't fully pinned down like with many cancers, but we know it stems from a series of genetic mutations in those colon and rectal cells.
Okay.
These mutations mess up the normal controls on cell growth, leading to uncontrolled division and eventually tumors. Environmental factors and lifestyle definitely play a part too.
Right. A mix of genetics and environment. Makes sense. Now, the risk factors. That list can seem pretty long.
Yeah.
What are the absolute key ones we need to remember for the MSRA?
Good question. The single biggest one, statistically speaking, is just getting older. Age significantly increases risk. Then a personal history of colorectal cancer or polyps is a major one, or even having had adenomas before. Family history counts too, of course.
Okay, age and history.
Right.
But you mentioned most are sporadic.
That's right, yeah. While family history is important, the majority occur in people without that strong link, which is why screening the general population is so vital.
Got it. What else is high on the list?
Inflammatory bowel disease, so ulcerative colitis or Crohn's disease definitely bumps up the risk quite a bit.
Right.
Then you've got specific inherited genetic conditions like Lynch syndrome or FAP familial adenomatous polyposis. They carry a very high risk.
Okay.
We're also seeing more evidence linking diabetes mellitus. And then there are the lifestyle factors, obesity, not being active, a poor diet, low fiber, high processed foods. And don't forget things like smoking, heavy alcohol use, maybe previous radiation to the area, and even a history of other cancers like endometrial, breast, or ovarian.
Wow, okay. That is a lot to juggle.
Uh-huh.
Is there any kind of mnemonic or trick to help remember the main categories?
We could try something like age and family, inflame, inherited diabetes, lifestyle adds other risks. Does that help?
Age, family, inflame for IBD, inherited diabetes, lifestyle, other risks. Yeah, that actually covers the big groups nicely. Helpful for recall under pressure.
Exactly. Recognizing these in a scenario is key for the MSRA.
Definitely. Okay, let's zoom in a bit. Pathophysiology, what's actually happening at the cellular level?
So it usually starts with those benign polyps in the bowel lining. Over time, sometimes years, these polyps gather more and more genetic mutations. Eventually, enough changes accumulate that they turn cancerous.
Right.
These mutations then drive that uncontrolled growth, letting the cancer invade nearby tissues and ultimately metastasize, spread to other parts of the body. It's like a slow-motion cellular breakdown.
A buildup of genetic errors leading to chaos. Clear. Now, if someone comes in with symptoms, what else might be causing them? What differentials do we need to have in mind?
Yeah, you always need to think broadly. Obviously, benign polyps themselves are on the list.
Okay.
Other inflammatory bowel diseases, like we mentioned, Crohn's and UC, can look similar symptom-wise. Diverticulitis or just diverticular disease is another big one, especially with pain and bowel changes.
Right. Diverticular disease is common.
Very. And colorectal adenomas, those precancerous growths, can bleed too.
What else?
Well, IBS, irritable bowel syndrome, can cause bowel habit changes, though usually without the more sinister red flags like bleeding or weight loss. Simple things like hemorrhoids can cause rectal bleeding, which is obviously a key symptom we look for in cancer.
True.
Then you've got to consider anal cancer, ischemic colitis, where blood flow to the colon is reduced, and even some rarer things like pneumatosis coli, which is gas in the bowel wall.
That's quite a spectrum.
Yeah.
Any way to mentally group these for exam questions?
I find it helps to think in categories, like you have other inflammatory stuff, you have benign or precancerous growths, you have functional disorders like IBS, and then local problems around the rectum like hemorrhoids.
Okay, yeah, grouping by type, inflammatory, growths, functional, local, that helps simplify it.
Exactly. Helps you work through the possibilities logically.
Good tip. Now let's talk scale. How common is this? What's the epidemiology in the UK?
It's unfortunately very common. It's the fourth most common cancer overall in the UK.
Fourth. Wow.
Yeah, accounts for about 11% of all new cancer cases. That translates to over 42,000 new diagnoses every year, and sadly, over 16,000 deaths annually, too.
Those are really significant numbers.
They are. It really highlights why early detection and effective treatment are so critical.
Absolutely. And who tends to get it most? Any demographic pointers?
Well, age is the big one, as we said. Incidence shoots up as people get older. Actually, about 44% of cases are diagnosed in people over 75. The most common site is the rectum. And a concerning point is that many cases are still diagnosed quite late, at an advanced stage.
Which obviously impacts prognosis.
Massively. Oh, and it tends to be slightly more common in white individuals compared to other ethnic groups in the UK. For the MSRA, definitely remember that strong link with older age.
Key takeaway there. Okay, so knowing how common it is, how does it actually show up? What clinical features should make us suspect colorectal cancer?
Symptoms really vary depending on where the cancer is and how advanced it is, but the classic red flags are things like a persistent change in bowel habit,
Yeah.
new diarrhea or constipation that just doesn't go away.
Mm-hmm.
Blood in the stool or obvious rectal bleeding is a major one. Unexplained abdominal pain or discomfort, losing weight without trying, and feeling constantly tired or weak.
Is there a way to remember those core symptoms?
You could use ABCFW, abdominal pain, bowel habit change, bleeding, fatigue, and weight loss.
ABCFW. Okay, useful. Now, I remember learning about differences between right-sided and left-sided cancers. Does that often come up?
Yes, that's a classic distinction and definitely worth knowing. Right-sided colon cancers often present a bit more vaguely.
How so?
Things like unexplained weight loss, iron deficiency anemia because of slow hidden bleeding, sometimes even a lump you can feel in the right iliac fossa. Because the right colon is wider, they often don't cause obstruction until they're quite advanced.
Okay, so more subtle systemic signs, maybe. What about the left side?
Left-sided cancers in the narrower part of the colon are more likely to cause things like colicky abdominal pain, more obvious rectal bleeding, and changes in bowel habit, like increasing constipation, sometimes leading to obstruction. Tenesmus, that feeling of needing to go but nothing comes out, can happen too.
Yeah.
And you might feel a mass on the left side. They tend to cause bowel habit changes earlier.
Right, so right side, anemia, weight loss, often advanced. Left side, obstruction, bleeding, bowel changes, maybe earlier symptoms. Makes sense. What are the absolute must-know symptoms that should ring alarm bells?
The critical ones to always have front of mind are rectal bleeding, unexplained, a persistent change in bowel habit, again, unexplained, and iron deficiency anemia, especially in older people without any other clear cause. Spotting these in an MSRA scenario should definitely trigger concern.
Got it. Bleeding, bowel habit change, anemia. And what about signs of more advanced disease, things that suggest spread?
Yeah, if it's spread, you might see things like jaundice or an enlarged liver hepatomegaly suggesting liver mets. Ascites, which is fluid in the abdomen, could mean peritoneal spread. Much rarer signs could include things like pneumaturia air in the urine, suggesting a fistula to the bladder or abscesses near the rectum. And DVT can sometimes be associated with underlying cancer. The most common sites for spread are the liver and lungs, but also brain and bone.
Okay, so local symptoms can mask wider spread,
Mm-hmm.
right? If we suspect it based on these signs, what's the investigation pathway, especially thinking UK practice for the MSRA?
First steps usually involve blood tests, a full blood count looking for anemia, liver function tests.
Standard stuff.
Yeah. And then really importantly in primary care now, there's the quantitative fecal immunochemical test, the AAT test.
Yes, FAT.
It's very sensitive for tiny amounts of blood in the stool. You need to know the nice East criteria for using it in symptomatic patients. Basically, it's for adults aged 50 or over with unexplained abdominal pain or weight loss or changes in bowel habit, and also for those 60 or over with unexplained anemia.
Okay, so specific age and symptom criteria for FIT. What happens if that's positive or if someone meets the urgent referral criteria anyway?
Well, the gold standard for diagnosis is usually a colonoscopy, or sometimes a flexible sigmoidoscopy if the suspicion is more for rectal or sigmoid pathology.
Right, visualization.
Exactly. You can see the lining directly and take biopsies to confirm if cancer cells are present. Then, for staging, figuring out how far it spread, we use imaging.
CT scan.
Yeah. Typically contrast-enhanced CT of the chest, abdomen, and pelvis for colon cancer. For rectal cancer, MRI is often better for looking at the local spread. Sometimes PET scans are used too. And we also measure CEA levels in the blood. It's a tumor marker. Not great for diagnosis, but useful for monitoring after treatment.
Okay, biopsy confirms the imaging stages. How is the staging actually classified? I remember Dukes and TNM.
That's right. Duke's is the older system, simpler, A to D, based on how deep the tumor goes and if it's spread. But the one used universally now is TNM.
TNM.
Yeah. T stands for tumor, how far it's grown through the bowel wall, T1 to T4. N is for nodes, whether nearby lymph nodes are involved. N0 for none, N1 or N2, depending on how many are where. And M is for metastasis. M0 means no distant spread. M1 means it has spread to other organs like the liver or lungs.
Okay, T-depths, N-nodes, M-mets. Clear.
And we also talk about grade G1, 2, or 3, which is how abnormal the cells look under the microscope. G1 is well differentiated, looks more like normal cells. G3 is poorly differentiated, looks very abnormal.
Got it. That T&M breakdown is really useful. Now, super important for MSRA, those urgent referral criteria for metastasis. Can we recap those clearly?
Absolutely critical. Okay, so urgent 2-week weight referral for adults aged 40 plus with unexplained weight loss, A&D abdominal pain.
Okay, 40 plus weight loss, A&D.
Adults aged 50 plus with unexplained rectal bleeding.
50 plus bleeding.
And adults aged 60 plus with either iron deficiency anemia or R changes in bowel habit. Also, consider referral if someone under 50 has rectal bleeding plus other symptoms like pain, weight loss, or bowel habit change.
Right, those age and symptom combinations are vital to know.
Definitely. Knowing when to refer urgently is non-negotiable.
Okay, so someone's referred, diagnosed. How do we actually manage colorectal cancer?
It's always a multidisciplinary team effort. Surgeons, oncologists, radiologists, specialist nurses. The plan depends hugely on the stage, the location of the cancer, and the patient's fitness.
Makes sense. What's the role of surgery?
Surgery is the main curative option for localized disease. The type of operation depends on where the tumor is. For the right colon, it's usually a right hemicolectomy. Left colon, a left hemicolectomy. Sigmoid colon, a sigmoid colectomy or high anterior resection.
And for the rectum?
For rectal cancers, it might be an anterior resection if it's higher up, preserving the sphincter, or an abdominoperineal resection, APR, if it's very low down, which involves removing the anus and creating a permanent colostomy. The key is removing the tumor with clear margins and the nearby lymph nodes.
Okay, so surgery tailored to location. What about radiotherapy and chemotherapy?
Radiotherapy is really important mainly for rectal cancer, especially locally advanced cases. It's often given before surgery neoadjuvantly to shrink the tumor and make surgery easier and reduce the chance of it coming back locally.
And chemo.
Chemotherapy is used quite a lot. For stage 3 colon cancer, where nodes are involved, we usually give adjuvant chemo after surgery to mop up any stray cells and reduce recurrence risk. For advanced or metastatic cancer, chemo is the mainstay, often combined with targeted therapies nowadays.
Targeted therapies. Like what?
Things like cetuximab or bevacizumab. They target specific pathways involved in cancer growth, but only work for certain genetic profiles of the tumor.
Right. And what if the cancer has already spread, say, to the liver?
Even with metastatic disease, there can be options. If the spread is limited, for example, just a few spots in the liver, sometimes surgery to remove those liver metastases, often alongside chemo, can still offer a chance of long-term survival. For more widespread disease, treatment focuses on controlling the cancer and managing symptoms. There are other drugs like regorafenib for patients whose cancer has progressed after other treatments. Lung mets might also be tackled with a mix of treatments.
So even metastatic disease isn't always hopeless. What about follow-up after treatment?
Oh, follow-up is crucial. Patients need regular checks to watch for any signs of the cancer coming back. This usually involves clinic appointments, blood tests, including that CEA marker we mentioned, and regular CT scans, typically for about 5 years. NICE has specific guidelines on the frequency.
Right, staying vigilant for recurrence. We talked about urgent referral to diagnose. Are there other key referral points within the pathway?
Well, the initial urgent referral based on symptoms or a positive FIT is the gateway. Once cancer is confirmed, the patient is discussed in the specialist MDT, and that team coordinates the management plan and any necessary referrals between surgery, oncology, etc.
Okay, let's talk outlook. What's the prognosis generally like?
It really depends on the stage at diagnosis. That's the single most important factor.
Early stage versus late stage.
Huge difference. If it's caught early, when it's localized or only spread regionally, the chances of successful treatment and long-term survival are much better. If it's already spread to distant organs, stage 4, the prognosis is unfortunately much poorer.
Can you give any figures?
Broadly speaking, for those who have surgery with curative intent, around 60% might survive 7 years or more. The overall 5-year survival rate across all stages is about 45% compared to similar people without cancer. But the good news is survival rates have been improving steadily in the UK.
That's encouraging. So, stage at diagnosis. is absolutely key.
Paramount.
Thinking about prevention, though, what can people do to reduce their risk?
A lot of it comes down to healthy lifestyle choices, the things we often hear about. Eating a balanced diet with plenty of fiber, fruit, and veg, limiting red and processed meat, staying active, maintaining a healthy weight, not smoking, and limiting alcohol intake. Those are the big ones with the strongest evidence.
What about supplements or medication?
There's some research suggesting things like folic acid, selenium, maybe calcium, or even low-dose aspirin might play a role, but the evidence isn't as solid or clear-cut as for lifestyle factors. Aspirin seems linked to lower risk in some studies, but it's not a general recommendation for everyone due to bleeding risks.
So focus on the lifestyle basics mainly. Finally, what are the potential complications we might see, either from the cancer itself or the treatment?
The cancer itself can cause problems like blocking the bowel completely, obstruction, or even perforating, making a hole in the bowel wall. It can invade nearby structures too. And of course, there's this spread lymph node involvement and distant mets.
And complications from treatment.
Sure, surgery carries risks like infection, bleeding, or problems where the bowel is joined back together and anastomotic leak. Chemotherapy and radiotherapy have their own side effects depending on the specific drugs or doses. Use things like fatigue, nausea, nerve damage, changes in bowel function.
Okay, a range of potential issues to be aware of. Well, this has been incredibly thorough. We've covered a huge amount for this colorectal cancer deep dive.
We really have. From the definition causes, those crucial risk factors, remember, age and family, inflame, inherited diabetes, how it develops, what else it could be, how common it is.
The symptoms, ABCFW, right? First left, differences investigations like FIT, the TNM staging, referral criteria.
All the management options from surgery to chemo, the prognosis linked to stage, prevention, and finally complications. Hopefully that gives a really solid grounding for MSRA revision.
Absolutely. Those mnemonics and key points like the referral triggers should really stick. Remember, early detection and knowing those risk factors are vital.
Definitely revisit this if you need a refresher during your prep.
And for loads more revision resources, head over to PassThemSRA.com and also check out FreemSRA.com.
We really hope this has been helpful. All the very best with your MSRA preparation.